Welcome to the series where I'll be discussing the 2026 Consensus Statement on the Algorithm for Management of Adults with Type 2 Diabetes by ACE. This is Endo in a Bite, where I break down endocrine concepts or lengthy guidelines into focused, high-yield pieces you can actually remember. For the full board-centric framework, I've built it all out in easy endo prep, designed to keep you efficient, current, exam-ready, and sharp in clinic. Visit www.ezendoprep.com to enroll in the full course or start your free trial. Today's focus is heart failure in the setting of type 2 diabetes using the complication-centered treatment approach. In this framework, the presence of heart failure directly guides medication selection. The priority is to choose therapies that improve heart failure outcomes while also addressing glucose control. The first-line choice is an SGLT2 inhibitor with proven benefit in heart failure. These medications are recommended regardless of current glucose levels, regardless of whether metformin is being used, and regardless of other glucose-lowering therapies already in place. This reflects a shift toward outcome-based treatment. SGLT2 inhibitors are now established as foundational therapy in heart failure care. They carry Class 1 recommendations for heart failure with reduced ejection fraction and have demonstrated benefit in heart failure with preserved ejection fraction. In patients with type 2 diabetes, these agents reduce the combined risk of hospitalization for heart failure and cardiovascular death by approximately 20 to 25%. They also improve heart failure-related symptoms, including functional capacity and daily activity tolerance. These effects are consistent across a wide range of patients. Benefits are seen regardless of left ventricular ejection fraction, background diabetes therapy, or concurrent heart failure treatment. Meta-analysis data further supports their role. Compared with placebo, SGLT2 inhibitors reduce hospitalization for heart failure by 32% and reduce cardiovascular death by 15%. These findings reinforce their central role in treatment selection. An additional agent to be aware of is sotagliflozin. Sotagliflozin is a dual sodium glucose cotransporter inhibitor affecting both SGLT1 and SGLT2. It has regulatory approval for the treatment of heart failure, including in adults with type 2 diabetes and elevated cardiovascular risk. Its indication is specific to heart failure management, and it is not approved as a glucose-lowering medication. Attention can then turn to GLP-based therapies. The evidence for heart failure outcomes with these agents is evolving. A meta-analysis of 8 cardiovascular outcome trials showed an 11% reduction in hospitalization for heart failure with GLP receptor agonists. In heart failure with reduced ejection fraction, the data does not show improvement in key outcomes. Liraglutide did not demonstrate benefit in time to death, rehospitalization for heart failure, or improvement in left ventricular ejection fraction. An increase in heart rate of about 6 beats per minute was observed, along with a higher rate of serious cardiac adverse events. In heart failure with preserved ejection fraction, especially in the setting of obesity, the data is more encouraging. Semaglutide, at a dose of 2.4 milligrams weekly, has been shown to improve heart failure symptoms and physical limitations. Tirzepatide has also demonstrated benefit. In the SUMMIT trial, adults over 40 with obesity and heart failure with preserved ejection fraction were studied, with nearly half having type 2 diabetes. Tirzepatide reduced worsening heart failure events by 46% and reduced heart failure hospitalizations by 56%. These findings support consideration of incretin-based therapies in obesity-related heart failure with preserved ejection fraction. Medication selection also requires attention to agents that can adversely affect heart failure. Saxagliptin has been associated with increased hospitalization for heart failure. Alogliptin has shown a trend toward increased heart failure hospitalization in post-hoc analysis, and caution is appropriate, particularly in more advanced heart failure. TZDs increase fluid retention and can exacerbate heart failure symptoms. These agents are avoided in symptomatic heart failure. Pioglitazone is contraindicated in New York Heart Association Class 3 or Class 4 heart failure. Let's summarize. For a patient with type 2 diabetes and heart failure, initiate an SGLT2 inhibitor with established heart failure benefit. Dapagliflozin or empagliflozin are appropriate first choices. Remember the letters, D followed by E, DAPA, EMPA. Then remember, sotagliflozin may be considered for heart failure management based on its approved indication. Further decisions can incorporate the type of heart failure. In reduced ejection fraction, SGLT2 inhibitors form the therapeutic foundation. In preserved ejection fraction, particularly with coexisting obesity, incretin-based therapies may provide additional benefit. Medication review remains essential to avoid agents that may worsen heart failure, including TZDs and certain DPP-4 inhibitors. This approach aligns treatment selection with clinical outcomes, prioritizing therapies that reduce hospitalizations, improve symptoms, and lower mortality risk in patients with both type 2 diabetes and heart failure. For this episode, remember the medications: dapagliflozin, empagliflozin, sotagliflozin, semaglutide, and tirzepatide. This was another bite-sized episode of Endo in a Bite. If a detail went by too quickly, don't worry. I've prepared the notes for you. Visit www.easyendoprep.com to sign up for the weekly newsletter and have all the key pearls delivered straight to your inbox. You can also purchase the full board review course there for deeper learning and ABIM exam preparation. Remember, stay consistent, and together we'll work through the ACE consensus statement on the algorithm for the management of dyslipidemia, one bite at a time.